My name's Jim Bolton. I'm consultant with a psychiatry team based in a general hospital. And a common reason for referral to my service is a patient with medically unexplained symptoms. I'm going to discuss this topic, which gets relatively little time in the medical curriculum, but takes up an awful lot of time of practicing doctors. I'm going to discuss what medically unexplained symptoms are, think about how common they are, discuss what causes them, because if we can understand what causes them, we're in a better position to know what we can do about them. The learning objectives from the curriculum that this talk will cover include the concept of medically unexplained symptoms generally, but also briefly describing the key clinical features of three disorders: somatoform, hypochondriacal and dissociative disorders, and thirdly outlining the management of a patient with medically unexplained symptoms. A large part of what doctors do is discussing signs and symptoms with a patient, eliciting these through history taking and examination, undertaking appropriate investigations, and all of this helps to identify the underlying pathology. This enables us to reach a diagnosis for a patient and thereby to determine what management they require. But quite often, a patient's apparently bodily symptoms are unexplained by physical pathology. Some people are surprised to hear that in primary care, this will be up to 1 in 5 referrals. And in outpatient clinics in a general hospital, the proportion of patients presenting with medically unexplained symptoms, symptoms not explained adequately by underlying organic disease, will be something in the range of 1/4 to 1/2. It's as many as 1/2 in certain specialties like neurology, gastroenterology and cardiology. So as you can see, it takes up a lot of time of practicing doctors. This list comes from research in general practice and gives some of the symptoms that most commonly patients present with that remain medically unexplained, starting with muscle and joint pain, low back pain. If you look down the list, these are often common human experiences. I, for example, will have experienced most of these in the last couple of weeks. What's different between me and a patient, though, is that I haven't chosen to present these problems to a health professional. And that begins to give us a little bit of a clue about what might be going on. One lady who gave me another clue as to the origin of medically unexplained symptoms and why they're so difficult for us to understand was my grandmother. Over 80 years of accumulated wisdom, and when she heard that I was not planning to be an orthopaedic surgeon anymore but was now training in psychiatry, she said, "That's all very well, dear, but when are you going to be a proper doctor?" And like many people, my grandmother doesn't see mental health symptoms as legitimate as physical symptoms, as though the mind and the body were two separate things that experienced two different sets of symptoms. We perpetuate this mind-body divide in our thinking and language. We think about ourselves as separate minds and bodies. A psychiatrist is sometimes said to be a doctor of the mind, but I'm not even sure what a mind is, and I've certainly never seen one in a jar. I only ever meet whole human beings. But even in our health service, we distinguish between mental and physical health, and often we separate the services geographically from each other. So where does this artificial distinction between the mind and the body come from? Well, there are a number of reasons, but one of them includes the invention of the light microscope, because this encouraged the idea that physical symptoms should be due to observable pathology. For example, people could now look down a microscope and see cancerous cells, or the bugs that were causing an infection, encouraging the idea that symptoms are due to something we can see if only we look hard enough, and therefore there will be positive findings on examination or investigation for somebody's bodily symptoms. But there remains a problem, as I've indicated, in medicine when physical symptoms remain medically unexplained by purely physical causes. If patients present to a medical or surgical clinic and the doctor tries to reassure them with a statement like, "Your investigations are normal," these are some of the things that patients tell me that they actually hear. What the doctor implied was that your problem isn't real, or you're putting it on, or you're mad, or in order to denigrate someone's problems we might say, it's all in the mind. That will simply leave a patient who walks out of the clinic still with their symptoms and probably feeling quite disgruntled, and a doctor who is often dissatisfied that they've not got to the root of a patient's problem. If we try and go to the books and look and see whether we can make a diagnosis in cases of medically unexplained symptoms, this is a potentially very confusing area. There are a wide range of diagnoses that we can choose from, and what's more, different specialties in medicine tend to speak different languages. For example, in psychiatry, we tend to make a diagnosis in the case of medically unexplained symptoms by using a theory about etiology. Here's some examples of diagnostic categories that involve medically unexplained symptoms. One is somatoform disorder, where patients present with physical symptoms that are actually part of underlying psychological distress. Hypochondriacal disorder occurs when somebody has a persistent disorder, formerly called hysteria, involves the presentation of physical symptoms, neurological symptoms, without an underlying physical neurological cause. As you can see, all three of those have something in common, and often it's hard to determine or choose which of those diagnoses to pick in a patient's case, and sometimes they may fit a number of categories. That's unsatisfactory in itself, but what's more, if we turn to the other medical specialties, they have different diagnostic terms. Different specialties tend to recognise clusters of symptoms that commonly occur together. For example, gastroenterologists may see patients with irritable bowel syndrome, a cluster of abdominal symptoms such as bloating, change in bowel habit, nausea, that remain unexplained by purely physical causes. That gets the name of irritable bowel syndrome, or IBS. Chronic fatigue syndrome is recurrent and disabling mental and physical fatigue, often with other physical symptoms, again, all of which remain unexplained by purely physical mechanisms. Atypical chest pain often presents to cardiology when patients present with chest pain that sounds cardiac in origin, but actually the patient has a normal myocardium. Fibromyalgia, multiple tender and painful pressure points across the joints and muscles of the body without any physical abnormality in the underlying tissues. So what we have are a range of possible diagnoses, some of which overlap with specialties speaking different languages. We really make a hash of this. So in recent times, there's been a tendency to step back from the confusing diagnostic terms and ask, what do all these patients have in common? And that is that they have apparent physical symptoms not adequately explained by physical pathology. And so people have tried to give these umbrella terms, such as functional disorders, implying that there's a disorder of function and not structure. Probably the term that's most vogue in the NHS and research at present is that of medically unexplained symptoms, sometimes called medically unexplained physical symptoms, and that's the term I'm using in this talk. It's a useful starting point for diagnosis, an umbrella term recognising that what all these patients have in common are bodily symptoms not adequately explained by physical pathology. The next step is trying to work out what causes this problem. It's useful at this point to step back and think about what a symptom is. The Oxford English Dictionary says that it's a phenomenon arising from and accompanying a disease. This implies a direct relationship between a disease and a symptom, such as that if we ask the patient enough questions, we could directly work out what their underlying illness is. But you don't need to spend long in medicine to realise that it's a more complicated process than that. Here's a slightly more complex model. In order for any of us to experience a symptom, we first of all need to perceive something wrong with us, an ache, a pain or a niggle. We then need to interpret it. We may ignore it as something insignificant or trivial, or we may decide that it might be an indication of a serious illness. It then becomes a symptom when we present it to a health professional. And then we adopt the appropriate behaviour. As the sociologists would say, we adopt the sick role or manifest illness behaviour. What I should say at this point is that many physical symptoms are due to the perception of organic disease. People will be arriving in casualty departments today experiencing crushing central chest pain that they correctly have interpreted as being evidence of underlying heart disease. But similarly, many people will present with similar symptoms when they turn out to have a normal myocardium. Many such symptoms remain medically unexplained. So what factors from clinical experience and research are associated with medically unexplained symptoms to help us understand them better? What I'll offer you is a chronological breakdown of etiology, looking at the predisposing or vulnerability factors to medically unexplained symptoms, what tips people over into a problem, the precipitating factors, and what maintains or perpetuates the problem. Considering vulnerability factors first of all, family and twin studies have demonstrated that there's probably a genetic contribution to a number of medically unexplained symptoms and syndromes, for example chronic fatigue syndrome and irritable bowel syndrome. But it's not as simple as a one-to-one relationship between a gene and an illness, and this probably depends on a multifactorial etiology involving environmental factors. It's not necessarily very helpful in an individual patient's case. What might be more useful is to consider things from the patient's history about their own experiences of illness. For example, childhood illness. We know from research that patients who have been hospitalised as children, particularly with painful illnesses, are more likely to present with medically unexplained symptoms in later life. The experience of parental illness and how parents handle illnesses in families can also be important. I remember as a child, if I suggested to my mother that I thought I should have a day off school because I felt unwell, she would simply give me my bag and push me out the door. And you can see how that might influence the way I deal with physical symptoms in later life. Childhood abuse can be important. Physical, emotional, and even sexual abuse are significant vulnerability factors for medically unexplained symptoms. But they're also general risk factors for a range of psychiatric disorders. Illness beliefs can be important, the way we think about our bodies and what we understand about them. For a time, I was a junior doctor working in infectious diseases, and I knew if there was a television programme about meningitis on television one week, my on-call the next week would be very difficult because the emergency department would be full of patients presenting with headache and a concern that they might have meningitis. And then we can consider the factors that tip people over into developing medically unexplained symptoms. Life events are recognised to do this. Life events are significant stressful events in people's lives. They're also a general risk factor for episodes of a range of psychiatric disorders such as psychosis and depression and anxiety. But as well as individual stressful episodes, chronic stress can also play a role. Things like relationship difficulties, money worries, housing and job problems. And medically unexplained symptoms are sometimes triggered by initial physical illness or injury. Chronic pain, for example, can develop after an injury that involves nerve injury, even though the nerves appear to have healed. And chronic fatigue syndrome is often triggered by significant viral illness, such as influenza, hepatitis or glandular fever, but the symptoms of chronic fatigue syndrome persist even when the immunological reaction is over and the infection has been cleared from the body. And what factors keep medically unexplained symptoms going? Maintaining or perpetuating factors. Anxiety and depression can certainly do this. Most of us know that if we're feeling low or stressed, any other problems we have feel 10 times worse and more difficult to manage. So anxiety and depression can amplify physical symptoms, and the symptoms may in turn get us down and lead to our mood getting worse, and a vicious circle can be set up. It's also worth bearing in mind that anxiety and depression are not simply disorders of the mind, but also have a range of physical symptoms, and if we don't recognise that these are linked to the mood disorder, they may remain medically unexplained. The reaction of other people can be important as to whether we present with a problem. I've talked about my mother's reaction to my physical symptoms as a child. Other parents may react differently, and a child may be more likely to present with a problem. And iatrogenic factors are important. Factors due to the health service, doctor-made factors. In my practice, I have met a number of patients who have medically unexplained symptoms, and when I ask them what they do when the symptoms come on, they describe taking a medication that would otherwise be used to treat a physical illness. What message does that give if somebody is prescribed a medication for physical illness when it's been concluded that their symptoms have no underlying physical pathology? For many people, it simply reinforces their idea that there must be something important going on that people aren't telling them. So can we fit some of these predisposing, precipitating and perpetuating factors into that simple model of symptoms that I offered you? For example, I may be travelling here today to film this talk. I'm already somewhat late, that gets me anxious. I then find myself in a traffic jam on the way to the hospital. That gets me stressed. My sympathetic nervous system gets going and I'm pumping adrenaline into the body. I'm getting close to the hospital, but then I get cut up at a set of traffic lights. That delays me even more. That gets me particularly angry. So my heart is beating harder and faster now, and actually I'm beginning to feel a little bit breathless. I start to worry because I know I've got a strong family history of heart disease. At that point, as I sit in the queue, gasping for breath, I phone home, and my nearest and dearest says, "Don't forget that your grandfather died of an early age of a heart attack. Do you think you should really carry on, do that filming? Shouldn't you see somebody about this?" So instead I interpret my symptoms as something important. I take myself to the emergency department. They check me out and say, "Dr. Bolton, your heart is perfectly fit, your blood pressure and your ECG are fine." They try and reassure me, but then they say, "And by the way, we'll book you in to see a cardiologist in a few weeks and we'll undertake an exercise stress test in the meanwhile." That leaves me simply thinking there must be something wrong that they don't want to tell me about, and my medically unexplained symptoms are up and running. That model, that example may seem slightly crude, but examples of that often play out with patients that I meet. Next, I'll offer you some thoughts about managing such medically unexplained symptoms when they arise. We can think of a stepped care approach, where we use interventions of increasing complexity for more severe and intractable problems. So I'll start with basic management that we might use in any medical clinic, specialist management that I might use when I meet patients referred to me by other colleagues in medicine, and finally recognising that several people have intractable problems and we're into the realm of damage limitation. So when assessing somebody who potentially has medically unexplained symptoms, it's important to elicit a patient's concerns and beliefs. Asking a simple question like, "What do you think is wrong?" can be important. If there is a patient presents with chest pain and their fears about their family history of heart disease aren't discussed, this may still bubble away at the back of their mind. Simply asking a question about what do they think is wrong or what concerns they have will enable that to be discussed with the doctor. It's also important to identify any significant background stresses. I've talked about the role stress can have in the onset of medically unexplained symptoms, and that may come from a basic social history. We shouldn't then forget to screen for alcohol and drug misuse. The use of alcohol and drugs comes with a number of physical symptoms, particularly situations of withdrawal and alcohol withdrawal. And those symptoms may be misidentified as somebody isn't aware they're related to substance misuse. We shouldn't also forget caffeine, which is a sympathomimetic. So, for example, somebody who drinks a lot of tea, coffee, and other soft drinks that contain caffeine may experience a whole range of physical symptoms that they may not be aware is due to the chemical in the drink. We should also screen for anxiety and depression, and I've talked about how the symptoms of anxiety and depression can be misinterpreted as medically unexplained symptoms. Often when I'm talking to a colleague about medically unexplained symptoms, they will ask, "Well, how much should I investigate a patient?" And my answer is, as much as is appropriate. That's not intended to be unhelpful, but to recognise the fact that most doctors recognise what the basic investigations are for a particular problem and where they might be going too far. We may think that by conducting more detailed investigations of a patient's problem, this will help to reassure them when the results are negative. But in fact, over-investigation can simply reinforce a patient's conviction that there must be something physically wrong if only we looked hard enough. And of course, that might help to perpetuate the problem. It is important to reassure patients, but what I would say is that bland reassurance is unhelpful. What is key is to address a patient's fears and beliefs. I've talked about perhaps an unspoken fear about heart disease in the family or concerns about cancer. And that's an opportunity also to correct any misconceptions people may have about the way their body works and the origin of their symptoms. As I said, bland reassurance is unhelpful. What that must go hand in hand with is some sort of explanation for the problem, a positive explanation of how the symptoms arise. And this involves putting the mind and the body back together again to explain how physical, psychological and social factors interact to cause physical symptoms along the lines that I previously suggested. This process is sometimes called reattribution, enabling a patient to reattribute their symptoms from a purely physical explanation to perhaps a more complex one that recognises there are whole human beings that don't function as separate minds and bodies. One way to broach this subject with the patient is to first discuss the bodily symptoms of emotion. This helps people to recognise that our psychological state, our social situation, can have a profound impact on the body and cause physical symptoms. Blushing as an example. In a social situation where we might feel scrutinised, we have a psychological feeling of embarrassment, and that causes flushing of the face or blushing, a physical response to a social situation and a psychological or emotional state. Butterflies in the stomach are similar. Most people recognise the experience of butterflies in the stomach, an uncomfortable abdominal sensation that occurs when we feel anxious or frightened. And that might be a way in to helping people recognise that we're not separate minds and bodies, and the two are very closely linked. Common explanations I use with patients include the vicious circle of pain and depression. In patients with chronic pain, where the pain brings their mood down, a low mood will amplify the experience of pain and a vicious circle is set up. And sometimes I suggest that the way to treat the pain is not to give it an additional analgesic, but to actually tackle the depression with antidepressant medication or psychological therapy. The concept of hardware and software is a useful explanation for many people with dissociative disorder. Dissociative disorder is the presentation of neurological symptoms without an underlying physical basis. For example, pseudoseizures or non-epileptic attack disorder, where patients experience seizures that look identical to that of epilepsy, for example, grand mal or tonic-clonic seizures, but actually aren't accompanied by the electrical activity that goes hand in hand with epilepsy. And with such patients, I might use the concept of hardware and software, likening the human body and nervous system to a computer. It has hardware, the brains and the nerves, that runs programs, or software that enable us to think and to feel and to move. What we think might happen in dissociative disorder is a problem with the software. I know that if I use my computer at home, I haven't fiddled with the wiring, the hardware is intact, but occasionally it will seize up or just stop working completely. Perhaps, for example, I have too many windows open on the computer. A problem has gone wrong with the software. And we can use that analogy with patients, for example, with those with pseudoseizures. The idea that the mind can become overwhelmed with stress that interferes with the software, the programming of the nerves, and the mind shuts down, too many windows are open, and people fall to the floor and have a seizure. A problem that's to do with the software and not the hardware, caused by underlying stress. Probably the commonest mechanism I discuss with patients as an origin for medically unexplained symptoms will be the fight or flight response. The evolutionary mechanism we've evolved to deal with stressful situations. When human beings were evolving as cavemen on the plains of Africa, it was useful to have a mechanism that got us ready for physical action in a hurry, such that if a saber-toothed tiger jumped out in front of us, we could either fight the tiger or run like mad, both of which involve expending physical effort very quickly. So in situations of stress, the evolutionary mechanism, the fight or flight response, releases adrenaline into the system and gets the sympathetic nervous system going. Our hearts beat harder and faster to pump blood out to the muscles that need to be active. We need to get oxygen into that blood, so we breathe more quickly and more deeply. We don't want to waste time digesting food, so we divert blood away from the gut out to the muscles. And we need the muscles to be tense and ready for action. All of this will enable us to fight the tiger or run. The problem with modern life is that we're rarely required to expend physical effort in situations of stress, but this mechanism may still get going, leaving us with the physical symptoms of the fight or flight response. If we don't recognise their cause, we may misinterpret this as evidence of an underlying physical illness. If my heart beats harder and faster, I may be concerned that I have a heart disease. If I'm breathing more rapidly and more deeply, I may be concerned that I'm developing asthma. My tense muscles may lead me to think that I'm developing a cause of tremor, such as Parkinson's disease. So the fight or flight response can be the origin of many apparently medically unexplained symptoms. We can then think about patients who need more intensive treatment, specialist management, patients such as those that I would meet in an outpatient clinic. Often such people have chronic problems, may well have presented to a range of different specialties with a number of different medically unexplained symptoms. They may come with several volumes of notes and have been seen by many different specialties. But the reasons for the problems always seem to remain unclear. The patient is referred back to the GP and perhaps a few months later on to a different specialty with a different range of symptoms. The poor patient finds alternative explanations other than the purely physical difficult to accept because they've undergone multiple consultations and examinations and investigations to look for a physical cause for their problems. If I meet someone in the clinic, one of the main aims of that first meeting is to build a relationship with the patient. I want to be able to work with them and for them to come back and see me again. Part of doing that is enabling someone to talk through their medical career, about all the problems they've had, the investigations they've undergone, the patients they've seen. That might be a very long discussion. As a psychiatrist, what I do then is broaden the agenda to take a more detailed social history and to think about their personal lives as well. There may be an opportunity as I do that to make links between significant stressful events in their personal lives and when their symptoms were at their worst. Towards the end of the meeting, there'll be an element of education. Perhaps I'll talk to them about the bodily symptoms of emotion as a way of understanding how the mind and body interact. I may offer them a tentative, suggested explanation for how their symptoms may arise. And I will often do something like setting them a simple task, like keeping a diary for a week or two, a diary of their physical symptoms to describe them when they're at their worst, but also to indicate what the situation they were in when those symptoms arose. And also, if they can, to think about how they were feeling at the time. That may all be a very long meeting. One of the country's experts in this area advises leaving at least 3 or 4 hours if you know you're going to meet somebody with an extensive history of symptoms. When I talk to colleagues about this, they may balk at the amount of time I suggest spending, but actually I think it is time well spent. I liken it a bit like to a surgical procedure. We would think it a nonsense if the hospital managers went into the operating theatres and said, "Mr. So-and-so, you've had your time for this complex cholecystectomy, your hour is up, please stitch up the patient and come back next week." Similarly, this long meeting has an important therapeutic element. It's not just an information gathering exercise, and it's important to make a relationship with the patient and help them to feel understood so that they are likely to come back next time and we can begin to make a headway with their problem. I know from experience that if I interrupt someone halfway through their account of their symptoms and say we'll come back to it another time, they're much less likely to come and see me again because I'm just another doctor who didn't listen. What sort of management strategies can I use with such patients? Well, I'll often consider antidepressant medication. I may, for example, think I'm dealing with the physical symptoms of anxiety and depression, and by treating these directly, the symptoms should improve. One lady I recall seeing had a 3-year history of precipitous weight loss. By the time I met her, she was cachectic. She'd been investigated by a number of medical specialties, all seeking a cancer that ought to be the cause of this dramatic weight loss, but nothing had been found. And my colleagues in gastroenterology recognised that all of this was getting the lady down, so she was referred to my service because of concern about depression. And we did talk about how low she'd been feeling. Her depression had been going on for about 3 years, ever since her husband had retired from work. The two of them had been stuck at home together. They didn't get on that well. They argued a lot of the time, and she described how as her mood got lower, she lost her appetite and she'd stopped eating. This turned out to be the cause of her weight loss. With prescription of antidepressant and advice that she get out of the home at least once a day to escape from her husband, her mood quickly improved, her appetite came back, and she began to put on weight. I've also mentioned how physical illness and depression can amplify each other, and treating the depression may be a way to treat the problem, particularly in chronic pain. But also in chronic pain, we know that a number of the antidepressants, particularly the old tricyclic antidepressants, can have an important direct analgesic effect and may be useful for that reason. And we also know from research that antidepressant medication can be helpful with medically unexplained symptoms, even in the absence of depressive illness, for reasons we don't fully understand due to the complexity of the brain, but there's evidence for their effectiveness in conditions like irritable bowel syndrome, chronic fatigue syndrome, and as I've mentioned, chronic pain. Psychological therapies can also be useful. There's most evidence for the effectiveness of cognitive behavioural therapy, therapy that addresses how the way we think and behave can lead to our symptoms. There are examples from somatization, chronic fatigue syndrome and other disorders where CBT is effective. It's also worth considering whether psychodynamic therapy and understanding plays a role. After all, this is where Sigmund Freud made his name. He was originally a neurologist who became interested in women who collapsed for medically unexplained reasons. and that's how he developed his interest in explanations of the human psyche. What psychodynamic therapy involves is the understanding of a patient's problems in terms of their past experiences and their psychological defense mechanisms, the way they deal with stress. Some of the etiological models for medically unexplained symptoms that come from psychodynamic therapy include the importance of childhood emotional deprivation. We learn how to deal with stresses, with difficult feelings, with other people as we grow up. We learn this from our parents and caregivers. But children who grow up in situations of emotional deprivation or frank abuse may not get the opportunity to learn appropriate emotional coping skills. Hence, as adults, they may lack appropriate emotional responses. They may even lack a vocabulary for describing their emotions and how they feel psychologically rather than physically. Hence, symptoms, physical symptoms, may be a way of expressing underlying difficult feelings. They may also be a defense against difficult feelings. It may be more comfortable for a patient to talk about how they feel physically than how they deal psychologically and to consider all the experiences they've been through. We should also recognise that there are some people with chronic and severe symptoms that are resistant to treatment. Most GPs will recognise one or two patients in their practice who may be bedbound or dependent on a mobility scooter, where neurological investigations, for example, have been unremarkable. There is no physical explanation for the patient's problem, but they're severely disabled. As I say, it can be difficult to make headway with an intractable problem, especially when somebody's life has then become built around their disability. But straightforward things we can do is to try and limit unnecessary investigations and appointments. Make sure that other medical specialties have an understanding and are aware of what's been found about a patient's problem. Perhaps that will help them to decide when to draw the line on further investigation. And often GPs or colleagues in medical or surgical clinics can contain consulting behaviour with regular appointments. Patients who may often present in an emergency situation to the GP may then decide, instead of waiting for the patient to present again, they will actually book them another appointment in a few days' time, whether the patient is feeling well or not. And then with those regular booked appointments, reassuring the patient that they will be seen, they can gradually extend the time interval between these and wean the patient off their regular consulting. I said at the beginning that one of the learning objectives for the course involved basic understanding of three particular diagnoses from psychiatry that relate to medically unexplained symptoms, so it's worth just touching on these again. Somatoform disorders. These involve the repeated presentation with physical symptoms without a primary physical cause. Hypochondriacal disorders. This is a strong conviction held by a patient that they have a serious underlying physical disorder, for example, heart disease or cancer. And this conviction is despite reassurance and negative investigations. Dissociative conversion disorder I've mentioned. This is neurological symptoms without a primary physical basis, and is dependent upon a putative psychological process of conversion and dissociation, hence the name for the disorder. The concept is that intolerable psychological stress is converted into a physical symptom, and this is not a conscious process but a psychological defense mechanism, and that involves a process of dissociation or splitting off from conscious awareness that the mind is actually doing this, that stress is being channeled into a physical symptom. So a process of conversion and dissociation, the implication being it's an unconscious process that protects the mind from intolerable stress. Once the stress is channeled into a physical symptom, that physical symptom for the individual is easier to bear than the original stress. One concern that people have about medically unexplained symptoms, particularly about making a positive diagnosis of such, is that we might be missing something, missing a serious underlying physical illness. This concern was backed up by research from the 1950s and 60s, which indicated that when patients were given a diagnosis of hysteria, now called dissociative conversion disorder, that up to a third of them, with long-term follow-up, would go on to develop significant physical neurological illnesses, such as multiple sclerosis. However, subsequent research, which looked from the 1970s onwards, found that we were diagnosing medically unexplained symptoms much less often, in a rate of about 5%. This is actually equivalent to other medical and psychiatric disorders. So we can be much more confident than we used to in making a positive diagnosis of medically unexplained symptoms. There is also some interesting recent research that begins to shed the light on the neurophysiological basis of some of these problems, again helping to put the mind and body back together again. Functional neuroimaging has been done in patients with dissociative disorder, particularly looking at patients who have a paralysis of the arm. A paralysis is not explained, for example, by an underlying stroke. They have been compared with patients who are pretending to have a stroke, who are feigning a paralysis. And then the imaging of the brain is looked at, particularly at areas involved in the planning and execution of movement. And what this has found is there are differences between subjects, people feigning illness, with those with dissociative disorder, where we suggest that there is an unconscious process. And those differences appear to indicate where the neurophysiological basis for this unconscious mechanism may lie, to reinforce the fact that we think they're not putting it on. So to wrap up then, medically unexplained symptoms are common in all medical specialties. The term medically unexplained symptoms in itself is not satisfactory because, of course, these symptoms are not truly unexplained. They're only unexplained if we think in purely physical terms. Explaining them depends upon consideration of physical, psychological, and social factors, and recognising that we are not really separate minds and bodies. I hope I've convinced you of my argument, but I think my grandmother is going to be a tougher nut to crack.